We now move to a panel discussion on male factor infertility, bridging andrology and ART, moderated by Dr. Praveen Joshi. May I request our esteemed panelists to kindly join us on the stage for the discussion. Dr. Sitaram M, Dr. Sanjay Prakash, Dr. Mohammad Ashraf C, Dr. Jasneet Kaur, Ms. Hira Bojamma.
Can we have Dr. Ashraf and on the stage? One more chair only we need.
Dr. Ashraf is just joining us.
Yeah. Quickly, we'll go through. We have had a detailed discussion about azoospermia management. Now, this case is a case which actually we have seen. 34-year-old lady and 38-year-old gentleman, infertility for 8 years. And all the parameters are normal in history. I'm going to summarize the case for you guys so we don't waste time in trying to say what do you want to do next. So primary infertility, ladies' cycles are regular and AMH is 1.8 at this point in time. This was almost 2 years ago. And male evaluation was revealing right side grade 2 and left side grade 3 varicocele. So the female factor has been found to be normal at this point in time as advised by our colleagues. Male factor shows a oligoastenospermia. Count is 12 million per ml. Motility 8% progressive, 12 non-progressive, and 1% normal forms. I am giving you the DFI report also, 33%. I would like to know from the panel, Dr. Jasneet, if this comes to you in Chandigarh and urologist or andrologist is not available in your system at that point, how would you like to take it forward? This is the information patient has come to you.
So this is something we've had a huge discussion on male infertility, but I think which is required because we are seeing a huge increase, especially in our setup. But I think at times we do not have the luxury to wait for 6 months for some intervention to act, if it will. She is 34 with an AMH of 1.8, which was done 2 years back. As
No, the entire case scenario is 2 years ago.
Okay. So she is 34 presently with an AMH of 1.8. I would ask for an andrology opinion, definitely. And there is a clinical varicocele with an abnormal semen parameter. Now for the surgery to act, it might take probably 6 months to 1 year for a varicocelectomy to give me results. So I think I will explain it to the patient and ask her that, you know, her AMH might really go down. And probably even after 1 year, I would be saying probably everything is the same, but your AMH is now on the lower side. Would you
consider an IUI or IVF at this point in time, Dr. Jasneet?
So it's up to the patient. I'll give her the option of probably undergoing a varicocelectomy and explaining that the results might take probably a year if, you know, there is going to be any improvement. On the other hand, she can directly go ahead with IVF ICSI as well.
Okay. So you are in favor of correcting the male factor at this point in time and give them some time to...
If her reserve, if I feel her anterior follicular count is good
Let
enough,
us say AFC is around 6 on one side and 4 on the other side.
It's again a borderline case, but probably yes. But
okay.
Clinically, what I'm doing in my practice, I am not suggesting varicocelectomies. I would rather prefer and go ahead with IVF ICSI.
IVF ICSI. So Dr. Ashraf, if the case were to come to IVF, what would be your preparation for this couple? How would you want to give an embryologist advice in order to prepare for the ICSI planned?
Now, in terms of DFI, particularly at Milann, we have an holistic approach actually. We don't just, with the routine phenomenon, we doesn't go. We have a holistic approach. One is short abstinence. I'll make sure that there is ultra short abstinence. That's one.
Could you explain to our audience what you mean by ultra short abstinence?
Now, ultra short means around 4 hours of abstinence. In a series, he has to ejaculate on daily basis. It's not just that ultra short. We'll ask the patient to ejaculate on daily basis. And on the day of pickup, I will ask him for about an abstinence time of 6 hours, which makes sure that whatever sperms that I am dealing with, there is no Ross fraction which is coming into play and affecting that sperms. I'm getting that fresh lot. And I have seen always, good results when I deal with short abstinence. That's one phenomenon that we do. Another thing that we do is microfluidics. We never skip that microfluidics part. So after the short abstinence, we do microfluidics. Through microfluidics, whatever sperms that we get, we make sure that the routine ICSI we don't do. We have something called as rheotaxis ICSI. Before that, we do zona binding. Now, what we do is that we take an oocyte, we put this particular oocyte in the PVP, immature oocyte, I would say, and we will allow the sperms to go and bind to these oocyte. And whichever sperm is binding to the zona pellucida of the oocyte and showing vigorous movement of the tail, we take those sperms. It's not easy. Once the sperm has been bounded to the oocyte, it's a task. So we do take such sperms, which again is far more superior than PIXI. PIXI is more of cumulus cell penetration. Now, with regard to zona binding, you're going one step ahead. That's one, and after zona binding, we do something called as positive rheotaxis ICSI. So these are the measures that we will take with regard to DFI, and also we strictly follow first cleavage should happen between 26 to 28 hours. We separate them. If we are doing individual culture, we'll make a note of it, which all oocytes has been fertilized and cleaved at 26 to 28 hours. All the morphokinetics will be noted down. Make sure that the blast which is coming very early on the day 5 will be given the first preference.
So the point here I want you guys to understand is, just because the sperms are there in the ejaculate sample, advising an ICSI, and I'm not against any embryologist or anything here. If you do not have this kind of a support system, advising ICSI with a high DFI is nothing short of a failure to the couple. Now, Dr. Jasneet also rightly said, she would give the option to the patients. That is the key here. I would like to ask Dr. Sanjay, this case were to come to you first in the outpatient, what would be your advice?
I would advise the same, because they are married for 8 years already, and also our AMH is just on the borderline looking good. I would tell them, yes, I would counsel them both the options. But you ask me as a reproductive urologist, even my ultimate aim is giving them a positive pregnancy. I would tell them that the same thing, whatever Dr. Ashraf told. So we just do the same way, put them on high antioxidants, and then go for a shorter abstinence sperm retrieval, and go first try your IVF. If you have any issues at the IVF, then subsequently let's consider correcting.
We'll come to that part in the second case. So you would agree with the other panel members?
Absolutely,
that
sir.
ICSI will be our first choice in this case? Dr. Sitaram differs here.
I would slightly differ. I mean, probably a different perspective, that's it. So as ma'am was telling, the egg reserve is less. We do a varicose seal. We wait for 6 months more. The egg reserve is going to come down, which is a valid point. So at that junction, I would also ask ma'am also on that, because I'm not the expert on female side. So can we give the
Oocyte
option,
freezing.
freeze the
freezing,
oocyte,
but yeah.
and then do the varicose seal repair, wait for 6 months, see the DFI, it's coming down, use the sperm and complete the ICSI.
Dr. Sitaram, would you really believe, as most of the doctors understand, varicocele correction takes 6 months to improve?
Yes.
Do you believe in that concept, or do you think 3 months, evidence says 3 months is the best improvement?
We have seen clearly that in 3 months you can see a drop in DFI significantly.
Yes.
So each
So the
1%, 6 is the maximum period we are
Correct.
looking at. That's not the minimum period, 6 is the maximum period we look at. If you don't see improvement in 6 months, unlikely you will see beyond 6 months. and it's the 3-month mark that we see the improvements.
So the point here is, don't go home with the impression that varicocele correction gives you the changes, it takes 6 months. The changes will start at 3 months and it is maximum between 3 to 6 months. Beyond 6 months, the changes might continue till another 3 months, but before, it won't go beyond 6 months generally. Whatever effect you have to see, you will see within 3 to 6 months. So, this couple indeed went for ICSI, not with us. They went in some other reputed center. And of course, none of you guys were asking for hormonal panel, but I'll still complete the topic. Hormonal panel is like this, normal range, but on the low normal testosterone levels. Ultrasound did pick up a varicocele, significant on both sides. We have already discussed what next. I don't have to again waste time on that. Now, they went for ICSI 2 cycles. That is the same case which will continue as a second case. Twice ICSI done. First time they didn't form any embryos. A reputed center, one of them in Bangalore, one of the centers in Bangalore. And second time they formed 1 blastocyst of C grade. Day 5 blast, C grade. Number of oocytes were 8 in first time and 7 in second cycle. That is the situation now. Now they came back to my OPD only 4 days ago in one of our branches, saying, "Doctor, what do I have to do now?" That is our second case. Now her AMH has come to 0.8.
So
We see this on a day-to-day basis. Don't we agree that?
Sir, I don't think there's any point of offering varicocelectomy with such a low AMH. I don't know, probably a TISA, if it could somehow decrease the oxidative stress, maybe, I don't know, but...
Probably, ma'am, the last scenario we discussed is more accurate now. You can freeze the oocyte because they have used the same sperm, did IVF twice and failed. You can retrieve the oocyte, freeze it, and after doing the varicocele surgery...
To add to the twist, now his count also has come to 4 million per ml and morphology has come to 0.
What is hormone, sir? How is his FSH?
FSH is similar range. Same, it was 7 point odd and now it is 8 point odd. Volume is similar. The findings in the scan and physical examination has not changed much. Parameters are changing.
One point I will add here, sir, that as we have discussed that TISA we can do, yes, that's an option, but the problem is the etiology here is varicocele. Varicocele oxidative stress damages the testis itself, so it is affected at the germ cell level itself. So the sperm is abnormal from the origin itself, so doing a TISA will not help in a case of varicocele DFI.
So the point here is, if you are offering TISA as an alternate source of sperm procurement in view of a high DNA fragmentation index, you are not helping the patient a lot. It may matter to some extent, but it is not the final step of your sperm procurement. Dr. Ashraf, any difference in the way you would like to look at it now?
So was microfluidics used in her last attempt? I mean, in the previous cycle?
Ma'am, we don't have that information. That's why I didn't put it up there.
Probably.
No, I agree with Dr. Ashraf. The way he and his team members put effort, it's not available everywhere. That's why the caution to the audience is, if you don't have this kind of a embryology team to support you, just don't jump into your IVF cycles. If they are there, yes, probably we can still find answers and give them success. But if not, a routine approach, as Dr. Sitaram was suggesting, if you're worrying about the oocyte availability, maybe you can freeze and do a corrective factor for the male and then take it one step at a time. A routine approach would be beneficial. But now the things have become worse. How would it change our approach to this case now? Would you all want to do varicocele correction, or would you want to freeze the oocytes, or do you want to take a chance and do one more cycle of ICSI with TISA? Which approach or which option can the patient take?
Oocyte freezing and varicocele is my option.
Yes. Dr. Sanjay?
I second the same option.
So both the uroandrologists are of the opinion varicocele ligation will be beneficial. Dr. Jasneet?
I give the option to the patient. And it's a difficult decision to make, so let the patient decide.
Absolutely. Dr. Jasneet is 100% right. The case must be discussed threadbare with the patient and with the couple, and they are the ones to make the decision. We as doctors, we may have 100 scientific points to make our choices. We should not be the ones to choose here. Our job is to display all the cards in front of the patient and let them pick up what they want.
But they end up asking, sir, what do you think is the best for us? So we should be able to tell them, sir.
All right. Dr. Sanjay is
Uncertain. So we are discussing means we ourselves are uncertain what to do.
So, Dr. Ashraf,
Yeah.
we do it routinely in Milann, but I don't know how many people do it. We keep sending you the cases ahead of the IVF cycles getting started to ask your opinion as to whether this case can be suitably managed or not.
Yeah. So in this case, when it is in the borderline 33 and all.
Now it has become 39.
Yeah. What we can do is that we will do all these interventions like microfluidics and positive rheotaxis. Post that, at Milann, we are doing it. We have to repeat the DFI and check on those sperms, the final yield, what we have got, where we stand now. So if the DFI has come down, I would say we can go ahead and inject. If not, it is better to freeze those sites. Rather than blindly freezing those sites, do a DFI check. See where we stand after all this. And still, if it's on the higher side, it's better to avoid injection.
Would you want to recommend your andrologic department to go for a varicocele correction if DFI continues to be high?
Definitely, definitely.
So, a responsible or a well, fully equipped and embryology team must evaluate the sperm ahead of starting another cycle of IVF ICSI. So if they give a go ahead and they show full confidence in your approach for ICSI, maybe it is still an option. Otherwise, if they say, no, this sperm looks bad, outcomes are going to be compromised, then better to have a mid-path approach, as Dr. Sitaram was suggesting. If you are worried about the female factor, freeze the oocytes, even pool the cycles, multiple oocytes frozen, and give the male factor a chance to get corrected. Then approach the completion of a ICSI cycle.
Just
So the idea.
one intervention here, sir. So we regularly advise microfluidics. We, andrology, embryologists, reproductive medicine, everybody advise microfluidics. But just one food for thought, I don't have any data to back my opinion, but DFI leads to recurrent pregnancy loss, proven beyond doubt in natural conceptions also. In natural pregnancies, 30% of recurrent pregnancy loss when DFI is high. So that means that sperm is able to navigate through the natural obstacles, swim up, beat the population of other sperms, reach the egg. That means that's supposed to be the best one. Got a pregnancy and then got terminated. So does really microfluidics is a system where we are using for DFI selection is similar to this one, but not even a natural process. So in DFI, does really microfluidics will make a difference? Because people with high DFA are getting pregnancies and getting miscarriages.
We will be running short on the third case.
So that's a food for thought. So I don't know.
So everybody can discuss with Dr. Ashraf and get his opinion. We are running short on time, so I have to rush quickly through the next case because this case involves our genetic specialist, Hira. It's a very straightforward case of I'm not going to waste my time on this. It's a case of a non-obstructive azoospermia with the primary testicular failure. And after repeated semen analysis, we have found no change in the semen parameters. So this is the hormone panel, high FSH, low testosterone, again indicator of primary testicular failure. Less than 2 size testicle. Secondary sexual characters of a male were little sparse. So we have gone ahead and got this information also for you to save time. Chromosome karyotyping has come 46XXY. So what is our situation now, Hira?
So good afternoon. Thank you for that question. So we already went through the biochemical investigation, and we already have a history of infertility in the couple. So we also have a diagnosis of Klinefelter here.
I came to this point directly because
Correct,
we need to
correct.
save some time.
Yeah. So when it is Klinefelter with no mosaicism, we are looking at a non-disjunction event that has possibly happened during meiosis 1 in the paternal meiosis. And definitely genetic counseling here is very important to convey the diagnosis to the patient, because again the husband's being directed here with the diagnosis, so there's a lot of psychosocial complications that might.
Can I break in there?
Yeah, yeah.
The patient and his wife, they will say, doctor, his father is normal. Why did he get?
So that's where you explain to them, draw it to them, tell them what really possibly happened, what non-disjunction, primarily is, where that, during the cell division stage, how adequate split of the gametes possibly didn't happen. And, a proper counseling is very important when you're explaining to the patient about their particular diagnosis. First of all, everybody is in denial about the diagnosis.
Understood.
So explain and then tell them the events of, genetics.
One chromosome report comes as 47XXY. Do you think it's required to do one more testing? Patient says, I
No.
doubt this lab.
No, I mean, so again, provided you've advised the test also, right? If you if you know a well-recognized cytogeneticist who's probably reporting your.
So the point is, there is no need to repeat and
Yeah.
recheck your chromosome karyotyping again and again. It will not change.
Correct. Yes.
Many people come with 3-4 chromosome karyotyping reports, and it's a waste of money. It needs to be
Yes.
told to the patients.
So I think proper counseling there would really help, sir.
Yes.
Yeah.
And would you advise anything? We go ahead and
Yeah.
Dr. Sanjay and Dr. Sitaram, what would be the approach for this case now? Answer will be straightforward.
Obviously micro TC, but we need to prime the patient up. The testosterone is low, less than 200.
Right.
We need to improve the testosterone, stabilize it for at least 2 to 3 months, and take for the procedure.
Right.
With PGT.
Sorry?
With PGT.
PGT. So I was about to come, Dr. Jasneet. So she already mentioned. So when micro TCA is done for this patient, concurrent OPU has to be done, because these are the sperms which are, if available, very precious. They will not sustain the process of cryofreezing and then thawing from that. Dr. Ashraf, would you agree to this point? So the routine non-obstructive azoospermia may work in a different way. In a Klinefelter, what would be the appropriate age by when we want to finish this?
So, straight answer, once the patient of Klinefelter hits 15 years, the spermatogenesis starts to decline, apoptosis starts at the age of 15. So earliest is the best. There is no maximum limit. Earliest is the best.
Yes.
Chance of sperm retrieval is going to be higher once he comes as soon as possible. Theory says around 35 years, but our experience, sir, will also accept less than 30 years, we are able to find sperms. When 31, 32, no, it's finding it very difficult.
So we have to strike a balance. Patients who with Klinefelter syndrome, the problem is it's a progressive imprinting problem. So the more and more seminiferous tubules get imprinted by the changes of Klinefelter, and spermatogenesis foci will start reducing day by day. So balancing between improvement of testosterone versus early micro TCA will be a key decision to get success rate. So, and Dr. Jasneet and Hira both pointed out that we have to do PGT when the embryo forms. So I brought out these 3 scenarios because it was not very difficult cases to see, but it's a routine day-to-day male factor problems that hit all our OPDs. So Dr. Ashraf, when let us say we get sperm in these kind of cases, obviously micro TCA sperm will be morphologically very abnormal. How do you make your selection? Now the whole thing is in your hands.
Now, to start with, actually, micro TCA, the sperms
Could
are
you, sorry,
very
could you,
fragile.
could you just describe to the audience, you have had so many bad cases of micro TCA, you have given success to that. How were the sperm what your juniors thought, what changed when you came and saw the sample. As a quick word on that.
Sometimes what happens is that they will not be fully formed. You can just see that beginning end of the tail and all. So there will be some confusions coming, whether it is a sperm, whether it is a spermatid, all that. So there is a way to go about it to exactly find out. You can do the viability test, all that.
So you need an experienced, good embryologist without whom microtissue is not to be done.
No, but
Please
in
proceed.
microtissue, what I really want to convey to everyone over here is that it's not exactly the same way that you handle the conventional ejaculate sample the way you handle. You cannot do ICSI that way. Now, in ICSI, what we do is that we all know that we take the sperms, we put into the PVP and all. Now, in microtissue sperms, if you put the PVP more than 10 seconds, I'm telling you, it's very fragile. There going to be osmotic shock. There will be this membrane damage which is going to happen to the sperms, and you will not see a good outcome, which is very important. What you should do is that you should put these sperms in the mops, and whenever you want to inject, you just take that sperm, put into the PVP, and even though you cannot immobilize also, sometimes if you have to break the tail, it may get stuck onto the dish. You have to give the laser and break the tail actually. So
Right.
these are all subtle things which plays a huge role. Now, when you deal with microtissue, one very important thing that I look on is that whether the microscope light, whether it is halogen or whether it is LED, especially when I'm dealing with microtissue cases.
Right.
Because I know these halogen lights, it generate heat.
Absolutely.
And this heat, these temperature fluctuations are quite, it plays a detrimental effect on the sperm. Have huge impact. Even
Right.
when we have these AHU, the air current which is coming and hitting the ICSI dish, if this oil get cooled, when you're dealing with microtissue sperms and all, again, that also will have a deleterious effect on the sperm. So it's very, as I said, it's very fragile. You have to literally take care while dealing with microtissue cases.
Right, right, sir. So last question, Dr. Jasneet. Sorry, go ahead, please.
Yeah, same, we can do that, but every center may not have that because your contrast has to change, the glass dish has to come. So provided if it is there.
But you think, okay, we'll be able to select sperms better in the cases with MC?
Yes, absolutely.
So my last question to Dr. Jasneet and Hira. If the couple were concerned in the beginning, before the microtissue was done, what would be your take on donor sperm?
I think give the option to the patient. Yeah. It's
Give the option to the patient. So even before a microtissue is conducted, which we know the success rate, the literature says successful sperm retrieval in Klinefelter is anywhere between 40 and 50%. In my practice or in my colleagues' practice, we have not seen such a high success rate. We have seen success rate of 10 to 15% at best. And with that low success rate, option of donor sperm must be discussed with the couple even before microtissue is planned. I had one more question, but then that will take a longer discussion. Anyway, that should be all for this given case at the moment. And
I had one doubt.
Yes, madam.
So when we are talking so much about DFI, I really wanted to understand the tests that we are using. I don't think they are validated well. Also, they cannot help us differentiate between single and double-stranded breaks. And the treatment and any intervention that we are going to do is just going to act on our single-stranded breaks. So, I mean, wasting patients' time for at times 3 to 6 months for an intervention which might or might not work, I think can be offered if we have the luxury of time.
Yes,
you know,
ma'am.
considering her age, but I think we really need to do a lot more on understanding the DFI and maybe validating our tests much more. I don't
Yeah.
know, sir. I mean,
So,
I'm really struggling with, trying to incorporate DFI in our daily practice.
Yes, ma'am.
Because I really don't know how much validity will it have, and how
Yeah.
much it's going to improve my outcome?
You're absolutely right. Dr. Sitaram has already explained SCSA technique will give you the answers of a single strand and double strand damage. The other test which will give you same answer is tunnel test. If you have the luxury of these two tests, you can use them. A single strand DNA damage you can manage with the TESA. Double strand DNA damage, TESA will also not help. So you have to go for the root cause correction. That's why Dr. Sitaram was so confident telling when varicocele correction is advised, even with DFI not very high, he was guiding that because of this reason. In presence of varicocele, there will be a double strand DNA damage very commonly. That's why I was saying correct that first, because TESA will not be the answer for such a situation. And incorporating into routine practice, we have certain guidelines, as in failed ART in the past, recurrent implantation failures, recurrent pregnancy loss.
Right,
All
so
that is a very
idiopathic male factor.
idiopathic
I mean,
male
and
factor.
unexplained infertility, I really don't know.
Yes, ma'am. It's a clinical decision. If there is no clinical varicocele, and then it is unexplained. But the moment you find a clinical varicocele in a male, it no longer remains unexplained. Now you have an explanation for the problem. And we have seen many couples cross the boundary and conceive quickly once the root cause is corrected. It's not very uncommon at all. So doing a DFI test will only help your management. Let us say if DFI were to come back as normal, then you know for sure you don't need to worry. You can proceed with your next plan of IUI or ICSI as per your choice. So I thank our esteemed panel members for giving their wonderful insights into all the three case management. Dr. Sitaram, Dr. Sanjay, Dr. Jasneet, Dr. Ashraf and Hira, you have been very, very helpful in solving these three commonly seen problems which always pose questions at every crossroad. Thank you so much for your participation and help. Thank you.